get to where we started with the last one. It won't be terribly long. So this is, this should be the physiology one. I'm pretty sure I have everything. Let's back up in case. Yeah, this is physiology. So we're dealing with blood vessel physiology. There's a certain amount of definition in this particular today's presentation. There is really going over the basics of what the circulation is like in the sense of what controls it, what doesn't control it. That's kind of where we are. We're some ideas of what blood pressure and about how we measure it and what it implies. And then we're going to get in, and we just started with the controls when we ended. So that's where we're in this one, depending on, you know, just sort of the ebb and flow of the presentation. So this ties into just kind of where we left off with the heart. That's why the two units are intertwined and why they combine those chapters. Like, for instance, in the Welsh Whole textbook, even though they separated in the PowerPoint sequence I'm using here, just because I'm more familiar with it. And I like the thoroughness of it, to be truthful. Cardiac output, same thing you learned about, milliliters per minute. Okay, it has to, blood flow has to be equivalent to that. Okay, uh, it's relatively constant. It's so as long as your heart's doing what it's supposed to do and your lungs are keeping up with oxygen and carbon dioxide exchange, all good. The question is how it's distributed. Again, we'll go back to fight or flight, something we built on back in autonomic nervous system in AP1. It redirects blood flow because of the situation to the heart and the skeletal muscles, maybe a little bit toward the skin just to get some cooling going on late stage. But that's about it. But so it's not that you have the same amount of blood that's effectively going on. If we want to think of cardiac output, we've just changed it in that sense and redistributed. So even anytime, even if you're sitting here, the blood flow is designed basically for a rest position. If you're active, if you go up and go to the bathroom and come back in, it changes even momentarily from that activity. So we're constantly just sort of shunting it around, would be the way to describe it. And we all and a lot of this is blood pressure and what impacts it and what's so darn important about blood pressure. Okay, and so basically it's a force. We measure it the same way we do whenever you see a pressure measurement, millimeters of mercury. I mean, my micro class did it when we talked about, okay, we used a different pressure measurement. Okay, we use PSI, pounds per square inch. That's a pressure measurement that we use when we're talking about autoclaving and sterilization. But conveniently for this, we use millimeters of mercury, and you're going to see that again, as particularly when we start to look at respiratory and different types of pressures that are there as well. Okay, so that's kind of and that's part of this, because in order for exchange to occur of oxygen and carbon dioxide, in order for nutrients and waste products to make their way at the capillary level, and for the kidneys to function the way they're supposed to and cleanse your blood and adjust the volume, these pressures are very important. And by convention, because they're easy to find and there's enough pressure, as you will see in a subsequent diagram, we measure them close to the heart. Okay, and really it basically keeps it moving. We use pressure, your blood pressure, just like concentration is in chemicals that we talk so much about. Pressure is a gradient of sorts, and basically it's a driving force for pushing things out and pulling things in. The idea of that, of what blood pressure effectively is, and we talked about it a little bit already. Okay, when we looked at the blood and we looked at the role of albumin in those proteins. Remember, they provided a pressure. We called it colloidal osmotic pressure. It's holding the water in. Blood pressure is pushing against those vessels. When it gets to the capillaries, there's still pressure, and it pushes fluid out. Reason all the fluid doesn't come out, there's proteins are too big to be pushed out. They hold fluid in. Eventually, when you get to the end of a capillary bed, as you will see, in this unit. Now, basically, it's all changed. The blood pressure, what they call hydrostatic pressure, is dissipated. And now the colloid osmotic pressure, the residual proteins, are going to pull it back in. They're going to overcome it. It reverses itself. That's the beauty of this system. And you're going to see the same thing in the kidney. So the kidney is designed to do things at a higher pressure, as you will see. So a lot of this is, to me, I'm so fond of, and I do it with relative infrequency. For years, I would do the AP1, and Dr. Robbins would do the AP2, or Dr. Mara would do the AP2. We're constantly flip-flopping around with this stuff. It's very interesting. And I do enjoy this because it's sort of like building on everything we did in AP1. So to me, it's understanding. Okay, so voila. What's important? Really, the resistance. What opposes it? So what really we're looking about how thick the blood is, how long the vessel is, but by far and away, the biggest factor is the diameter of the blood vessel. So there's a lot of things that impact it. Viscosity is pretty straightforward. It's the thickness. When we talked about blood generically, you might remember we talked about something called polycythemia. That's when people they could be blood doping, they could be at altitude where they need more oxygen carrying capability. They could have a medical condition that induces their blood to be thicker, or even a tumor of some type. So basically, that makes it thicker. The more formed elements, and proportionally, therefore, the less fluid. Okay, and so that's what viscosity is, a thickness. It's like the difference between, let's say, water and motor oil. So you get the idea. Motor oil is thick, has viscosity comparatively, and there's varying degrees if you did not know. Now, ways that you probably knew more than I did, because what I know about vehicles is about zero. And my son's telling me, "Oh, I said I'm having a little trouble with my oil pressure." He goes, "Well, just put thicker oil in." I said, "There's thicker oil?" He goes, "Well, yours 530, but still put some 1040 in, or that'll make it thicker." Thanks. It's okay. All I know about cars is what goes wrong, which is there's good news and there's bad news. My VW, is getting a major overhaul. That's the bad news, particularly that number he's going to tell me about. The good news is it's in Oakmont, so I can get to the Oakmont bakery. See, now it's just good news and bad news. In our house, whenever we're in Oakmont, we stop. You know what I'm talking about. Hey. Oh, they make a cranberry walnut bread I really like. My wife lives there late. Particularly, she's into those. So I'm good. I'm willing to try just about anything. Which about you? Oh. 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 I'm with you. I'm with you. Pardon me? Oh, stop. Toying with my emotions. Well, good. Leave me with an order. We'll talk. Come over. We'll talk. We'll have coffee. Yeah. That's a note from The Godfather, by the way. She's a neighbor, more or less. But yeah, regional neighbor. So moving on. So viscosity, if it's thicker, it's harder to push around. The length, it's there are. I mean, that's probably the least important factor because it really doesn't change, and there's nothing that's a ridiculously long blood vessel that you have to worry about. This is the player. Peripheral resistance. Okay, viscosity and blood length really don't change a whole lot. Okay, but the big player is this. That's the narrower that blood vessel is, the harder it is to be pushed against. It's going to increase the amount of resistance. And the reality is that's when we have high blood pressure. That bottom number is a measure of that. And it has to do with something we've talked about. You'll see it again here called sympathetic tone. Your sympathetic nervous system, even when it's inactive, has a certain degree of tautness on these blood vessels. And that's something that's sometimes hard to overcome over time. That's why that bottom number is a critical feature. That's there. So what happens is, this is another thing, when this sort of dovetails into immune system. We're going to talk about how the body heals itself with the immune system, and we just go through a process typically called inflammation. So blood vessels are two. Thicker stuff is along the edges of the tube. Liquider stuff is in the middle. That's what they call laminar flow. So you'll see when your body is trying to heal itself, it sends out chemical signals that alter the walls of the blood vessel in such a way that they latch onto white blood cells and allow them to come. It basically calls them to the party. Hey, we got a problem here. Something's broken. And it summons them. It's a very neat thing. So that's part of this idea of inflammation. And really, you begin to understand when you injure yourself why there is inflammation. It's supposed to be there. When it's not there, it's a problem. So this laminar flow is like that. Okay, and we're not going to ask you the question or do the math about it. But the interesting thing is when we widen a blood vessel like that, the resistance drops it's not inversely proportional, it's inversely proportional to like the fourth power. So if you have that, it's like 2 to the fourth power, the resistance is low. It's a very significant drop. Just go with it. We're not going to ask you to do it. I'm not going to give you the mass. We're not going to 2 to the fourth power. It's like n to the fourth power. It's okay. It's a math thing. I know that bothers people. I started college as a math major, these many years ago. So, blood vessel, small diameter arterioles. That's really where we control it. Remember, we looked at that diagram the last time. I mean, the aorta is massive. You can't squeeze that. Even these arteries here, effectively, you may be able to put pressure, but limited or for a limited amount of time to try to control. It's very hard to create a tourniquet effect on larger blood vessels. But when you get to those arterioles, particularly as you can't begin to not be able to see them, you can squeeze them shut. And therefore, they're the big players when it comes to peripheral resistance, when they come to blood pressure, when they come to blood flow. And what happens, anything that gets into it is not just a muscle squeezing it, but this is where we get atherosclerotic plaques, fatty plaques, irregularities on heart valves, irregularities in other blood vessels from damage. They disrupt that whole thing. That's laminar flow, that layered flow. If it's not that way, if there's humps and bumps and irregularities and mini blockages, it's going to create turbulence. Turbulence means clots, and when the blood clots, so all of a sudden it's either going to obstruct blood flow or that clot's going to break off and go to some place and stop blood flow. The kind of thing that leads to heart attacks, the kind of thing that leads to strokes. And as people get older, it's the kind of thing we used to see a lot in diabetic patients. All of a sudden, we start to get fingers and toes turning black. Something called gangrene. And it's never coming back. So you're either going to have to let it fall off or amputate it. And it's a whole issue. We talk about that a little bit in micro and wounds, less so here. Okay, and I'm not too worried about the straw, but it gives you an idea of the resistance. Then it's a milkshake. I just go the old fashioned. Save the straw. I'll deal with the thing. In my face. You ever watch Diners, Drive-Ins, and Dives when he eats something? He goes, if I got it on my face, is it on my mustache? That's me. Going, what? Look. Don't leave home without a paper towel in my pocket. In my pocket is a card carrying, I'm a slob. Slobs are us. So I have a slob card. And so I have to have a paper towel. I just dropped mine. I'm in trouble. Don't tell them. Not doing this. So blood pressure, the heart. So it's about flow overcoming resistance. If you want to look at it scientifically, yes, the steepest drop is in the arterioles. This is the chart that tells you all you need to know. We can only measure blood pressure where we have a distance. They're going to do this right away. It's called the mean arterial pressure. And the reason I wrote this 80 to 180, what effectively it means, our bodies, read that as your kidneys, can adjust satisfactorily and keep functioning, which if they stop, you're in big trouble. Okay, that's the type of stuff to get you in intensive care. From this, I know I was in intensive care when my kidneys failed, nearly 20 years ago. And so that number is called the mean arterial pressure. I'll show you the calculation in a minute. And the way we calculate it, these are blood pressure, blood vessels we can measure. Basically, we're looking at named arteries that we can easily determine their pressure depending on their anatomical location, or take a pulse depending on their anatomical location. Not all of them, but certain ones anatomically. But look here, once they get small enough and they classify as arterioles, basically either we can barely see them or we can't see them at all, then that smooth muscle around them can squeeze them tight, even to the point of closing them. And you can see how precipitous the drop is from really a mean pressure of about just slightly above 80, where all the way down here to 40. And so when they enter the capillary beds, they're at about 35 like here. This is the big player. That's why arterioles are really controlling your blood flow and so controlling your blood pressure. And what factors determine this with regard to the flow in the arteries? Something called compliance or distensibility, easy for me to say, or the volume of blood. For years, the only way we dealt, before we had an idea of how things work, before we had sophisticated medicines, if somebody had high blood pressure, the treatment was you made them go to the bathroom, you made them urinate, called diuretics. The trouble is they're not very efficient. They're not easy to tolerate because people can't. It's hard to do your job when you're constantly running to the bathroom. And unfortunately they lost a lot of potassium, and potassium can lead to arrhythmia. So already you're complicating a problem. So there was a lot of problems attended to it. We do use them in the hospital, by the way, okay, because we can control those other parameters and measure for irregularity and potassium and other electrolytes. The one you'll hear about, you don't have to know the name now, but you'll learn about is called Lasix, Lasix. The generic name is furosemide, Furosemide. So be familiar with that. Not for me, in the future. Nevertheless, okay, that's one factor, the fluid in the system. The other is how stretchy it is. It's like when you go to blow up a balloon and you take it out of a pack. I mean, it's hard to blow it up. What do? You improve. You kind of stretchy it out. Pull it this way, pull it that way, and you try to blow it up. Unless you got something, pump, you can just put it on and blow it up with. That's it. As you get older, that's why we tolerate subtle elevations in blood pressure for people. For years, they used to say, well, when you got to be middle age, like between 50 and 70, the bottom number could be 85. And if you're over 70, the bottom number could be 90. Nowadays, probably not so. Okay, people are living longer and they're healthier. If my bottom number of the blood pressure was consistently over 90 at age nearly 74, my family doc would be unhappy with me. Okay. So just say. So I mean, my numbers, I'm still more or less expected to be around that 80 85 range. So it changed a little bit, but that's something you lose that elasticity. What I'm trying to say, and so that's another one of the problems that's attended with aging. So and if the vessels have enough of that gap, so to speak, here, that's where we measure a pulse. So the top number, 120, just did that with cardiac cycle. Okay, basically that's what we're looking at, because that number will expand not only causes a pump into the aorta, but be maintained if we're taking that pressure somewhere close to the heart, here or here. Inherently, everybody will you'll see these. Maybe you'll have to use them. They have those wrist devices. Not very accurate. It's much more accurate to use a larger vessel, and it's much more accurate for you to do it yourself. And really, I've always been an advocate of doing the old-fashioned way and using the stethoscope and listening. When you pump it up to about 200, you typically pump it about 75 to 80 millimeters of mercury. So what's your usual pressure? About 120, 130? Okay. So for men, we kick it up to 220. For women, about 200. And you slowly let it loose. And you have it appropriate. You have it placed in the right area. You have the stethoscope in the right area. You listen for that first sound. That's the systolic. And when you keep hearing those sounds, they're called, you'll usually hear called Karatnikov sounds, not that you have to know that name. When the last sound is, that's the bottom. Because basically it's measuring when it starts being quote unquote pulsatile, and when the pressure finally goes below the level where you're putting any squeeze on those vessels, that's the bottom. That's how it works. That's for lab. If you do them in lab, fine. If you don't, many of you who are going to nursing or clinical fields, it'll work. So I don't love, though we do use them. But you'll see even in a hospital, if they, when I went in having, a minor non-invasive procedure, really minimally invasive, like my endoscopy, they've got the cuff on me, and while I'm sitting there, it's squeezing up every X amount of minutes and doing the same thing. They have a sensor that's on in the appropriate place, etc. So that's what basically is the lowest level where you could sense it when the heart is at rest. So how do we measure the average? We look at the difference, the pulse pressure, the difference between them, and obviously where we can sense those pulses by hand, but not necessarily a desirable place to take blood pressure. So what we're looking at when we do blood pressure is this. It's called the MAP, or mean arterial pressure. You saw that number before in that previous chart when they said mean. And so the pulse pressure phases out as it gets farther along. We can't measure it. They're too small, and there's not a big difference. So it's not pulsatile per se. So that gives us an idea of where it needs to be. And that's that number, that 80 to 180. Since the heart spends more time, roughly 2/3 of the time at rest and 1/3 pumping, we create this. So we take the classic 120 over 80. We get the difference, which is 40. And from that difference, we end up adding 1/3 of that, since it's only 1/3 of the time it's systolic, 2/3 of the time it's diastolic, and we add that 1/3 to the bottom number, whatever that number is, and we get the mean, 93. So pulse pressure and MAP decline as it gets farther away from the heart. So that's why it's an important number, because it gives you an idea, as long as you're in that number. So, I mean, if your number was close to 180 for a long period of time, you'd be in trouble. Your kidneys would be in damage, your blood, but your kidneys could sort of auto-regulate it to a certain degree. The longer it's there, the more damage is likely. On the other side of that, okay, you want it to be down in this lower area. For instance, my wife, who's only about 6.5 years younger than I am, her blood pressure is typically 110 over 60. That's not unusual. I see that in women. You see that in women who are slender or petite. You see that in women who are not slender or petite. We don't see it so much in men. Low blood pressure is not a problem. Low blood pressure to the point where it's at shock levels, that's a problem. So maybe if you took that 110 over 60, and I did the math quickly in my head, that would make her MAP about 77. But for her, that's a normal. So you can't say, oh my God, it's not 80 to 180. It has to do with what's normal for the individual, because their body have become accustomed to that. So we worry much more about high than people with low blood pressure. If anything, low blood pressure is probably associated with longevity to a certain extent. So that the bottom line is you want to keep your blood pressure under control. And so it's easy. We know what the vital signs are. the easiest way, and it's most convenient. Okay, because your wrists are almost always exposed. You see where the tendon is, it's over there if you do this. Okay, so that tendon, which I think is flexor carpi radialis off the top of my head. Don't have to know that. Did you learn that in anatomy? Carpi radialis, palmaris longus, flexor digitorum, flexor carpi ulnaris. Yeah, those four guys that are there, they make up basically the carpal tunnel area. It's there. Well, if it's on this side of flexor carpi radialis, just palpate. And right next to it, as you go to the lateral aspect of the anatomical position, well, there it is. Just don't press too hard because it's you generally use two fingers, and you can easily feel the pulse. That years ago, before they had that neat thing you put on the tip of your finger called pulse ox, we in order to do a pulse ox, we needed a pulse oxygen. Didn't have that, so you had to do an arterial stick. You had to stick it into the radial artery and get the blood into it and send it to the lab to actually determine the oxygen. Those are fun to do. And if you didn't see it with arterial blood, it's a very different color. Venous blood still has sort of a duskier red color, and it would even be duskier still. But the minute you take blood out and put it into a tube where you see blood, it's exposed to oxygen, it increases its oxygenation. The arterial blood has a higher degree of oxygenation. You can tell a lot by just looking at the blood that's there. So where are arteries close to the surface? And this is true. It's not always so convenient. You have to. You can stop. You can limit would be a better word than stop. I think if you're going to apply a tourniquet, most people do not. Here, you could stop blood flow, not into the entire hand, but you could at least stop it from leaking out of that. Okay, but to put, you need. I mean, taking a belt or putting a tourniquet on there is not going to stop the flow. It's going to limit it. Would be a better way to describe it. You need to crank up the pressure up here to 250 to 350 millimeters of mercury. Down here, 350 to 500. You can't do that by tightening a belt. So here are the pressures. This is the end. In the other class, I asked them about it. You did the carotid arteries. You have the common carotid, and then they bifurcate. You have the internal carotid going to the brain, the external carotid, sort of like cranial and facial, like the bones. That's why you do the bones that way. Cranial bones and facial bones. It applies to anatomy. So that you end up with the arteries here. The terminus of the external carotid is here, the superficial temporal artery. There are people where you can see this when their blood pressure is high. There's certain autoimmune diseases where it will be highlighted. So something called superficial temporal arteritis, inflammation of that. And it's almost like people will even sense it. Oh, I got a pounding headache. I can almost feel it. And that's the artery up there. So you theoretically get a post. Facial's hard, it's behind the jaw, but really the one that's better, and this is one you learn about in CPR, is the carotid. You're right. If you use the angle of the jaw as a landmark and go in, that's where you find that carotid pulse. That's really the pulse we use the most when you're determining CPR. Okay, the airway, breathing, circulation. The circulation, you want to see if that pulse is there. If not, then we have to do something about it. And you're going to see that's another important location, which we will not get to today when we start looking at special sensors in that area at the bifurcation of the carotid into the internal and external. There's something called the carotid sinus and something called the carotid body. There's also one in the aortic arch called the aortic sinus and the aortic body. The sinuses are pressure sensors, the bodies are chemosensors. They play a pivotal role in adjusting blood flow and particularly adjusting pulse to compensate for variations in blood pressure. And then famously, that's the brachial artery that is on the volar or flexor surface. It is located more medial than lateral. Okay? It's probably right alongside the belly of the biceps brachii muscle. That's where you want to put the sensor when you're doing blood pressure properly. It's a pet peeve. I mean, I've gotten into yelling matches. And somebody, I hate it when somebody who's, I don't want to paint with words, somebody who's not trained puts the blood pressure cuff here and the sensors here, or they put the blood pressure cuff so far down that when they inflate it, it makes your arm straight, which is not helpful. I remember tearing one of these off and going, would you please get somebody here who knows what the heck they're doing? I may not have used that terminology. It's okay. Just put it here. If you did not know, any of you going into healthcare fields, doctors make the worst patients. Pain in the butt. A royal, what we call an RPIA. If you know what I'm talking about. So, yeah, I'm the one they don't want to go into the room. Trust me, I'm that. We're awful. And then the radial artery is here. I find popliteal hard to get, and I know a lot about it. It's just hard for me to feel. Just as easy as the radial behind your median malleolus, super easy to get, posterior tibial. Posterior tibial is the anterior tibial artery comes down this way. So here's your shin on the lateral aspect, lateral of your shin. You can't feel it. It's buried in muscle. It comes superficial on the top of your foot. It's not that it's hard to feel. We have a tendency to push too hard on it. And it's easy to compress. Dorsalis pedis. So posterior tib is very easy to find. And the femoral artery, we don't use it ordinarily. For years, it was where we would catheterize people for cardiac catheterization. Because that, you would feed a catheter up, you squirt dye through the catheter, you take x-rays, almost like a movie of x-rays, and that's how you would catheterize. You'd use, basically see if the coronary arteries were filled or not. We have different technology today that we're able to do that less invasively, though sometimes you do have to do that. Why don't we do it? It's inherently risky. When you're feeding up the catheter and shooting stuff out of it, you could break off a blood clot. So I remember my dad had that done before he didn't survive the heart surgery, but they had to do another one. I mean, and they make you aware of the risk. He was also allergic to the dye, but thankfully, whatever dye they were using, he didn't have his allergic to iodine. So those all little things. I mean, that was a long time ago. My dad unfortunately died in 1988. It was a long time ago. So moving on, I prefer the standard methods using a blood pressure cuff called the sphygmomanometer. Manometer, by definition, means detecting pressure. Auscultation, stethoscope. Those are the sounds. You listen for the first, and you listen to when they go away. And those are the two numbers. You look at it. And you can do it without having to listen, interestingly enough. It's when it starts. The whole thing, oscillating is a fancy term. And when it ends oscillating, you can do it. So you can do it by observation. You can do it by auscultation. You can do it by oscillation. There's all sorts of things you can do. So the systolic, normally around that. The diastolic, the critical number, okay, because you're no longer putting any pressure on it and blood flows freely, so the sounds disappear. The whole idea of having that capillary blood pressure is so important, okay, because you need, look at the change at the start of a capillary bed, because here at 35 millimeters of mercury, and the kidney you're going to see is different. It has to be higher to achieve filtration. But at the start of the capillary bed, you need that pressure to overcome that colloid osmotic pressure. The proteins acting to hold it. That's the idea. At the end of the bed, pressure now is dissipated, so the colloid osmotic pressure is your friend. It pulls the fluid back in to fill it back up. And you're going to see this in subsequent slides. In this, it's similar in the kidney, but the kidneys are designed as a high pressure filter. So when it enters what we call the glomerulus, which we're going to do in class, it's way up at 55. But the arterioles are designed to withstand that pressure. It enters into the kidney. So it's a little bit different. It has to go through a different way in the kidney, so it doesn't quite apply. But typical capillaries would that higher pressure would be a problem. Most capillaries are very permeable, so low pressure, it doesn't take a lot, will push that out. So that may seem like a low number, but it's sufficient. And really, what happens in the pressure in your veins really doesn't change. Not too much at all. Your pressure in your veins stays about constant. We rely on what I drew up there. There's a lot of different pumping methods that oppose gravity. Because you would think if it stayed at about 15 millimeters of mercury, like the end of the capillary bed, it would have a tough time making its way back up to the heart from your feet and ankles, from your wrists and palms, because you have to oppose gravity. We have the advantage of having valves and veins. What I was trying to demonstrate up here was a side. I just have to know about it. But imagine, sort of like your heart helps. When your heart, think of this as your heart, and these are the vessels coming in, big vessels coming in, big vessels going out. When your heart pumps, it pushes the vessels out. But if you know what a siphon is, if you ever used one to siphon fluid out, we used to do that a lot when we ran out of gas. You try to get, maybe, I better get gas out of our other car so I can fill up some gas station. And effectively, when you squeeze it, pushes the blood that way, but when you release the squeeze, it creates a suction pressure. So it'll suck fluid in. That's how siphons work. So effectively, there's a lot of these, you can buy ones that actually work automatically, that are there, or just pumping it manually. So what happens is that you're able to have, we have certain ways, and you're going to see some of these pumps demonstrated. So, and that's the difference. Most of the time when you cut yourself, it's veins, it's on the surface. If you see an arterial cut, an arterial is called a pumper. You're going to see the blood going, it is scary. The blood looks distinctly different. So if you work in an emergency room, you see that, and people are going to be super excited because they see that they're panicking. I mean, if they're not taking care of somebody, can bleed out. You don't have a lot of wiggle room time wise. So the blood looks differently and it spurts out because of that pressure. And you got to put pressure on that big time for about 20 minutes to try to get that under control. And they need to get hold their extremity up if you can to offset some of the pressure. I mean, there's all sorts of things you have to do. I remember my buddy's mom got one of those really bad cuts in the kitchen, and all of a sudden it's pumping out of her thumb. And we're racing her to the local hospital emergency room. That so low pressure, lots of it. So small pressure gradient, low pressure is due to the cumulative effects of peripheral resistance. So we begin to lose it over the time. Low pressure on the venous side is adaptations. So these are the pumps. Your muscles squeezing are a pump. And because we have valves, we call it the column of blood. So there's a muscular pump, just the contracting your muscles as you're walking. It kind of milks it, pushes it back to the heart, and the valves prevent it from flowing backward. Same thing occurs respiratorily, flattening out our diaphragm, inhaling and exhaling our chest cavity, and the sympathetic has a certain residual tone that helps to push back up. This is what they're showing you in this diagram. It's pretty much points it out. So it's the same idea as the siphoning effect, but here at least you have the valves to help you. The valves squeeze the vein, it pushes what we call the column of blood up. When the muscles relax, those valves the backflow will close the valves as long as they're working properly. So the blood kind of moves up by segment. So it may be pushed up 3 or 4 segments. And when in between beats or in between muscular contractions, it'll stay there because the valves will, other than that, every time you took a long walk, you might get the blood up here and then all of a sudden it will go all the way back down to your feet. Doesn't work. So there's a lot of this that maintains those factors. We have cardiac output, we have the peripheral resistance, we have the volume of the blood. All of those are part of when we start to understand how we maintain blood pressure. The controls we have that hopefully work, or else we have to use other methods, typically medication. and they go into all the do that. This is the part. So we're going to look at the controls that are there. So this is we got pretty close to stopping right about here. So obviously, remember, stroke volume and heart rate increase cardiac output, and if the blood is thick or if it's a long vessel, typically they're pretty constant. The diameter of the blood vessels really is a big factor in resistance. And again, the two of those together really give you that mean arterial pressure. So understand that when there's a drop in blood pressure, for whatever reason, the areas where we're not going to see alterations, only to increase blood flow if necessary, okay, all the others constrict. You're trying to redirect blood flow to the two important areas. You've got to maintain it in the brain or the heart. They are the primary recipients of blood flow. After that, I would dare say kidney would be next. Sort of like a pecking order. And because we need to optimize blood flow to the heart and to the brain, depending on what is available, it will take it away from all the other organs, even the kidney. And if the kidney does not have sufficient blood flow for about 20 minutes, it will start to die. So understand think of this almost in an emergency sense of what your body is like, oh, so if we don't correct this, okay, for whatever reason, we have a problem. So most of the time it's controlled by these centers. We will look at pressure sensors, okay, and those are the ones that I told you we're in, where the carotid arteries bifurcate in the aortic curve, in the aortic arch. We can look at overrides in the higher brain center. The ones that typically keep everything under control normally are in those areas of the brain we really don't have any, we're out of our control. You might remember from AP1, we have the medulla oblongata and the pons. Most of your controls for heart rate, for respiration, for blood pressure in those areas. We can't impact them. How do we impact them? Oh, indirectly. We exercise, we eat properly, we keep an eye on our health and things that we control. So those centers are clusters of little sensors that are there in the medulla, and they will either inhibit or accelerate the heart. They'll play a role in what we call vasomotor centers. Those are that vasomotor tone I keep talking about. And all of that, they receive inputs from pressure sensors and chemical sensors. They receive inputs from the brain itself. But what they're trying to, that vasomotor tone is the residual tone in the sympathetic nervous system. That's the lower number of the blood pressure. That's the single most important part of what that represents. That bottom number of your blood pressure is the resting tension in those vessels. If it gets too high, I said it before, we were talking about the heart, you have to keep working over to push blood out. And it's fraught with danger. This is where I stop with the other group. We'll pick it up here. Get done a few minutes early today on the Friday. Thank you very much. Have a great weekend.